So that explains the acronym of HELP syndrome. Another thing that we do with our postpartum moms, and certainly we'd be doing it with our hypertensive mom, is assessing her deep tendon reflexes. And this is the scale that you're using when you document DTRs. 0 is absolutely no response to stimuli whatsoever. 1 plus is like a low normal, there's a slight muscle contraction. 2 plus, there's that word normal again, but 2 plus is what we're hoping to find. A nice muscle twitch contraction of the muscle down the arm or leg. 3 plus is brisker than normal, and 4 plus is very brisk, what we would call hyperreactive. And beyond even 4 plus, there's something called clonus. And clonus is a very abnormal pattern of neuromuscular activity. And what happens here, there's so much central nervous system excitability and irritation from all this hypertension. When you dorsiflex, when you push her foot up quickly, you have her leg out in the bed flat, and you push her foot up quickly, you will see this alternating contraction and relaxation of the skeletal muscle of her leg and foot. And what we're looking for is to see how many times that occurs until the foot completely relaxes. So I rapidly flex her foot forward, and as it begins to relax, if I see 3 episodes of this contraction and relaxation, or 3 of these jerks, I would say she has 3 beats of clonus. Or if it did it twice or once, I would say she had 2 beats or 1 beat. Hopefully we didn't see any. And interestingly enough, the word clonus comes from the Greek word for violent, confused motion, and indeed that's kind of what it looks like when you have tried to elicit this response to see if she has clonus. So lots and lots of central nervous system stimulation and irritability could be very close to having a seizure. Here's talking to you about positioning the patient for checking her DTRs. When we check her biceps, arm is flexed at about a 45-degree angle with her palm down, and you are actually going to use your thumb to find that bicep tendon, and you are going to tap on your thumb with the reflex hammer to elicit that deep tendon reflex to see what you have there. For the patellar, hanging her leg off of the bed if she could sit up, or more likely she's lying in the bed and you're supporting one of her legs at a 90-degree angle and tapping just right there at the lower part of the patellar, again observing for the amount of contraction at 0 to 4 plus and then the clonus. So suppose she is hypertensive. Suppose she goes from preeclampsia into eclampsia because she's had a seizure. Suppose she had a postpartum hemorrhage. Suppose any number of things happen and there's a critical situation. Well, what can you do to mobilize some extra help right away? Well, here on the Virginia Baptist Hospital campus, we have something called a Code O. And a Code O is the obstetric crisis code that's initiated, in your case, when a postpartum patient needs rapid evaluation and urgent treatment. We need extra hands here right now, and it's involving a postpartum patient. And let me caution you, don't confuse Code O with Code Orange. Code Orange is a hazardous materials spill. Code O is the obstetric code. So the whole purpose of this is with one call to mobilize a specific number of people who have a focus here on this OB patient to get them to the unit and provide the extra resources that are needed for that patient right there. We do not want her to get into a code situation. We don't want our Code O to go to a Code Blue. So mobilizing those people and those resources who will come directly to that patient's bedside. And as a bedside clinician, a nurse, a resident, physician, midwife, of course, any of us can call a Code O by dialing the emergency number 200-5911 when we feel this patient needs that extra help. So here's a list of some things from the Code O policy that says it might lead me to need to call a Code O. You just feel like you need additional help. Something's not quite right with this patient. You're not sure what it is, but something's not quite right. Certainly a postpartum hemorrhage, eclampsia or seizures, cardiac arrest, or we'd be calling a Code Blue there, pulmonary embolism, her O2 stat where she's under 90, you've got O2 on her and it's still an O2 stat under 90. Agitation, delirium, an anaphylactic reaction. My goodness, you come a new medication or something and she's got an anaphylactic reaction. An acute change in her heart rate, under 40, greater than 130. Maternal systolic blood pressure, less than 80 or over 200, or diastolic over 100. Respiratory rate, less than 8 or over 28. An acute change in her level of consciousness. Failure to respond to the treatment you have already provided her. So these things would certainly bring about that state of urgency where you would need to call that code O and have those resources there right away. Kind of ending here as we close what we're doing, just thinking about our concept here at family-centered maternity care. Let's all remember, birth is a normal life event. It's not an illness. And providing family-centered care, respecting each individual family's values, needs, their culture, their strengths, is part of providing that individualized care. Respect, collaboration, flexibility as we provide a plan of care for each patient, education, and empowerment of the new family are all key values in family-centered care, and that's the way we want to take care of our patients and address them and their families. So just always keep that in mind. The family is actively involved in decision making, and the whole concept of family-centered maternity care helps to give families the confidence they need to give them the skills they need to care for themselves and their new baby. And again, it's an integral part of our care planning here for our moms and our babies. So I thank you for your time, and that concludes the presentation on postpartum maternal assessment as far as the presentation. I do want to show you a couple of little things I have set up here as far as some demonstration, and then that will truly end it. Let's look for a moment at assessing this fundus in the postpartum patient. I talked to you about the importance of supporting the lower uterine segment as you massage her fundus. So right here I have a nice firm fundus right about the umbilicus. I'm right-handed. I tend to stand to the right of the patient. So here is my left hand, my non-dominant hand. Here is my right hand, my dominant hand, and I am placing my dominant hand right here at the symphysis pubis to support the lower uterine segment as I gently massage the fundus to make sure that it's firm, or if it was less than firm, in an effort to get it to be firm so there's minimal bleeding. But I'm always so careful to support that lower uterine segment here right at the symphysis pubis, so in massaging the fundus I am not running the risk of having the uterus turn inside out, protrude through her vagina, and have that prolapsed, that inverted uterus. So always supporting that lower uterine segment. Just a couple of examples here trying to help you understand. Here's a peri-pad that has just a small amount of bleeding on it. Actually, it's kind of spread out a little bit since I prepared it, but there's not a great deal of amount of bleeding. Maybe there's one clot the size of a grape, little bit of bleeding on the blue pad, but not much at all. And certainly we're fine with that. I would consider that very typical, very normal. Kind of hate to use that word, but I think you get my understanding. Here's a patient who has a little heavier amount of bleeding. Here's 3 or 4 little clots. Here's more bleeding that has come off of the peri-pad and out onto the chunks. I'm not calling a code O. I'm not alarmed and jumping up and down about this, but it's certainly more than what I saw on that first pad. This is going to raise my level of concern in that I'm going to assess her a little more often. Just a little bit of added assessment here to make sure it doesn't get to be any more than this, and hopefully it reverts back to being a smaller amount. Because left untreated, we could end up with the patient who could look more like this example here. You can see there's a tremendous amount of blood on this blue pad, almost totally soaked. Peri pad is soaked, some large clots, some small clots, just a large amount of bleeding. This is the woman who has clearly lost too much blood, large amount of bleeding. Maybe she has a boggy fundus. I'm going to be doing that fundal massage. I'm going to be calling for help. This may even lead me to call for the point of a code O if this continued. If I took all this away and put clean under her, and in 10 minutes it looks like this again. So what we've tried to do is just give you a little bit of visual to help your understanding as you begin to care for this patient population of what is typical, what's a little bit more than typical, and certainly what is that abnormal amount of bleeding, and help you as you start to learn to assess these patients. Okay?
Thank you.
Ah.